Good afternoon, and thank you for this kind invitation. I'm going to talk about molecular testing and the advantages and disadvantages. I have no financial disclosures. These are my learning objectives, which first is to identify when molecular testing should be considered in the evaluation of indeterminate thyroid nodules. Discuss differences in test methodology and summarize performance characteristics. And my third objective is to use genomic information to inform patient prognosis and management. So I'm going to start with a case, and this is a 43-year-old woman with Hashimoto's thyroiditis who was detected to have a left 2.2 centimeter thyroid nodule, and the picture is right here at the right corner. This patient had no risk factors or symptoms. Her TSH was 4.8, and she was not on levothyroxine supplementation. And when reading the ultrasound, this had an American Thyroid Association intermediate suspicion, which it's around 20% risk of malignancy, and an ACR TRAT score of T4. On the other images, there was no contralateral nodules or abnormal lymph nodes found. And on the cytology, after the biopsy, this was read as Bethesda 3 or atypical cells of undetermined significance. On the comment, there were occasional groups of follicular cells, demonstrated crowded architectures with overlapping pleomorphic nuclei, irregular nuclear contours, and fine chromatin. And that's how this was classified as AUS. So if we looking at the way we inform cytology, today we use the Bethesda category, and this is the last version by Sibas et al. Published in Thyroid in 2017. And on this last version, the NIFTP was included. And on the left, we have the risk of cancer / NIFTP, and Bethesda 1, which is considered as non-diagnostic. The rate of cancer was 5 to 10%, and the usual management was repeat FNA with ultrasound guidance. Bethesda 2 is benign with a rate of malignancy of up to 3%, and clinical and ultrasound follow-up is recommended. Bethesda 3 AUS/FLAS has a risk of cancer. Depending on the prevalence of malignancy of the institution, the risk of cancer is 10 to 30%, and the usual management is repeat FNA or perform molecular testing or perform diagnostic thyroid lobectomy. Bethesda 4 has a risk of cancer of 25 to 40%, and the recommendations are to perform molecular testing or perform diagnostic thyroid lobectomy. Bethesda 5, suspicious for malignancy, has a risk of cancer of 50 to 75%, and the recommendation nowadays is near total thyroidectomy or lobectomy, or molecular testing to determine the extent of surgery. And Bethesda 6 is malignant with 97 to 99% risk of malignancy, and the management is surgical with near total thyroidectomy or lobectomy. So what are the drawbacks of diagnostic surgery for indeterminate thyroid nodules? So ITN throughout this talk is going to stand for indeterminate thyroid nodules. So nearly 2/3 of patients get over or undertreated, and at least 20% risk of post-operative hypothyroidism, and that's how these thyroid molecular markers were developed. So what is the ideal molecular test? When we perform an FNA, we have 3 main results: benign, we cite Bethesda 2, indeterminate with Bethesda 3 and 4, and malignant, which is Bethesda 5 and 6. And the ideal molecular test should have a high negative predictive value. That means that the rate of malignancy is similar to a benign test, less than 3%, or benign cytology close to 97%. And then ideally, we would like also to have a test with high positive predictive value and ideally similar to malignant cytology, 97 to 99%. And this is a study of our group, Sarah Mason and Dr. Brian Haugen, published in 2019. So these molecular testing approaches are incorporating next generation sequencing technology, and they may use DNA, they may use messenger RNA, or they may use microRNA, depending on what's the company. And they evaluate for single nucleotide variants, indels, gen fusions, altered gene expression, copy number alterations, and combined testing platforms. So I'm going to mainly speak for the two most used tests in the US. There's another company that I'm not going to talk about since I haven't really used it. And the validation studies have been somewhat criticized. So I'm going to talk first about the Afirma GSC. And this study, which was published in JAMA in 2018, used the existing samples from the prospective GEC validation cohort, which was done on the pre-NIFTP era. They included 191 of the 210 Bethesda 3 and 4 nodules from 183 patients, and the benign call rate was 54%. So the summary of the study shows here GEC, and then the other study was the GSC. So there are different versions of Afirma. GSC would be the last version. So this, and this is the percentage of carcinoma. For the GEC, 32%, and for the GSC, 24%. So what I said, just the negative predictive value of these tests is really high, 93% and 96%. So that means that it's a very good rule-out test. And the cases that are called negative are probably the same rate of benign cytology, so around 3%, which is really great. And the positive predictive value, it's around 47%. And we're going to talk a little bit more about that. So what is the Afirma Expression Atlas? It's a whole transcriptome RNA sequence to detect gene fusions and variants. So it was updated in March of 2020 and included 593 genes, which included 905 variants and 235 fusions. The expression atlas is reflexively performed when the GSC is positive on Bethesda 3 and 4, or it's always performed when the nodule is read as Bethesda 5 and 6. On this little table that I'm showing here on the left, if we look at the number of alterations on most cases, in 46%, if we go for the GSC suspicious on Bethesda 5 and 6, on the GSC suspicious original, on the GSC suspicious expanded, the rate of one alteration found is around 42 to 46%. And on the GSC suspicious Bethesda 5 and 6, there was more than 1% alteration on just 1%. The caveat of this is that the expression atlas cannot detect variants in non-coding DNA, for example, third promoters. So in March of 2023, it was added. You could add on a DNA test for a third promoter variant. So now I'm going to talk about Thyroseq V3, which is performance of a multi-gene genomic classifier in thyroid nodules with indeterminate dermatology, and this is a prospective blinded multi-center study, which was also published on JAMA Oncology in 2018. And again, this is this multi-center. It was 10 clinical sites, one international, I believe it was Singapore. The international site, it was 286 Bethesda 3, 4, and 5 nodules, with a total of 257 informative molecular testing. So each genetic alteration gets a score of 0 to 2 for the rate of malignancy. And the score is based on, if 0 to 1 is called benign, or more than 2 is called high cancer probability. And the benign call rate was about 61%. Low-risk genetic alterations was found in 8% of the samples, which was given a score of 1, which is called currently negative. So on this thyroSIG version 3, or GC, the negative predictive value was 97%, very similar to Afirma GSC. The positive predictive value was slightly higher at 66%. So remember that with Afirma it was 47%. So the positive predictive value of thyroSIG V3 is slightly higher on this study. Of these 28%, there was 11 cases of NIFT-TP, and all were called positive. So none of them were missed. So what is the cancer probability and prognostication based on specific molecular alterations? Why do we want to know sometimes specific alteration instead of just the rate of malignancy? Because it does give you some prognostication. For example, on these patients, on this study, also published on JAMA Oncology, all these cases that were called thyroSIG positive. So 2% of these cases had high-risk alterations, and I put here what are the high-risk alterations, which are TERT, P53, PIK3CA, and the AKT1. And 100% of these were called malignant. This is the 2%. 12% have BRAF-like alterations, and again, this is considered malignant. It's usually papillary thyrocarcinoma classic. Now, 57% were RAS-like alterations, and out of those, 62% were called had a probability of cancer and NIFT-TP, and these are PTCs, follicular variants, follicular thyrocarcinoma, NIFT-TP. Copy number alterations, which are CNAs, is the abbreviation for that. Probability of cancer was 60%, a lot of cartil cell carcinoma, nowadays called oncocytic carcinoma, papillary thyrocarcinoma, follicular variant, and NIFT-TP. And then gene expression alterations, GEA, probability of cancer was 75%, and these are called medullary thyrocarcinoma, metastatic carcinoma, and papillary thyrocarcinoma. So it does help us to give prognostication on the type of tumor that the patient has. On the thyroSIG V3, the currently negative results, they had a score of 1. Remember, they had a score of 0, 1, and 2. And these nodules were harboring a low-risk genetic alteration that alone is expected to be a very low risk for development of malignancy. This was a retrospective study, and 468 nodules had negative thyroSIG V3 results. 391 were negative on surgical path, 31 were negative but limited and low cellularity, and 45, 8.8% were rated as currently negative. And out of that, about half of those were benign, and 17% had malignancy / NIFT-TP / well-differentiated thyrocarcinoma. So again, very indolent tumors on this little square box here. So this is a study that the authors tries to do a meta-analysis and see what's the performance of Afirma on the real world. And there was an inclusion of almost 2,000 patients. 1,300 plus were called benign nodules by GSC, and only 6% were operated. 651 were called Afirma suspicious nodules, and 78% were operated. So if you remember when we were talking about the Afirma validation studies, only 47% had positive predictive value, but in the real world is higher, 65%. But the difference is mainly because the ones that are called benign, most of these were not operated. And that's the main difference, that on the clinical validation studies, all the cases go into surgical path to validate this study. So that's the gap that we see here. This study compare how Afirma performs, and again, Afirma uses RNA versus Thyroseq V3 that uses DNA. And these are the number of benign versus malignant on both. And I want to say benign, 105. And again, this is the Afirma column. 12 of these nodules called benign underwent surgical resection. And on the Thyroseq, 10 nodules were resected of the benign column. So, in summary, the specificity was 68% for Afirma and 82% for Thyroseq. And the positive predictive value, 53% for Afirma, 63% for Thyroseq. The negative predictive value was very great on both, 100% for Afirma, 99% on Thyroseq. So for negative predictive value, both tests perform almost equally. For positive predictive value, Thyroseq has slightly better at 63% versus 53%. So how does molecular testing inform prognosis and management? So we're going to go back to our case, and this patient, Thyroseq was read as positive with an intermediate to high probability of cancer, called 60%, and the mutations found were IFAX and PTEN. And then we're looking at this column here. It's called the allele frequency, and I'm going to talk about this on the next slide. But the allele frequency of the IFAX was 13%, and the PTEN was 7%. And the combination of these two mutations on the same patient is considered intermediate to high risk of malignancy. So what do we know about the PTEN variant? This is the largest study published about PTEN variant on indeterminate thyroid nodules. This was found on 2.6% of these indeterminate thyroid nodules, and these are 48 patients, 49 total nodules. Most of the patients with PTEN had benign surgical pathology. So 28 patients had active surveillance, and we don't have the surgical path. 15 patients, 31% underwent resection, and we have the malignant rate of 7%, just 1 out of 15. And for the 5 who underwent total thyroidectomy, none of them had malignant. So the surgical pathology of the nodules resected, were 14 of them were follicular adenomas, 4 were oncocytic adenomas, 1 was an oncocytic hyperplasia, and 1 was encapsulated follicular variant of PTC. 2 had PTEN mutations and NRAS mutations. So all nodules with 1 or 2 isolated PTEN variants were benign. Now, what do we know? Okay, so then I wanted to clarify that when you see the report of Thyroseq, you say there's interpretation here, and it says the detected PTEN variant is likely germline. So what it means that if you look at the allele frequency, when it's around 50% or above, we think it's in the germline. So these are tumors that could be associated with the PTEN hamartoma tumor syndrome. And the clue here was the higher allele frequency, close to 50%, as opposed to our patient, I'm going back, which was just 7%. So mostly not a germline. So P10, it helps us for, it's part of the Cowden syndrome, where it's associated with some malignancies such as breast, renal cell carcinoma, melanoma, thyroid 35%, some benign thyroid nodules 75%, colon cancer. So it's a relatively common cause of syndromic non-medullary thyroid carcinoma. The typical recommendation is to do an annual screening like ultrasound study and diagnosis. If we are looking at the IFAX variant, was found on 4 to 5% of indeterminate thyroid nodules. It's found on both in benign and malignant nodules. So here's a little studies, 31 nodules each, and it was overall rate of malignancy 45%. And if we find the commutation of IFAX plus RAS, 80% were associated with carcinoma/NIFTP, the combination. IFAX plus other mutation, 80% carcinoma. IFAX plus TERT plus RAS plus TP53, where were 3 patients on these studies, 100% cancer. So it depends if they present separately or combined with other ones. So how does it help us for molecular prognosis? Because this is what we want for a patient. So if we look at the left pie here, when we have RAS alone mutation, we have 50% of these cases are adenomas. About 25% of these cases are NIFTP, and another 25% are cancer. So most cancers with isolated RAS mutations are low risk. For example, a follicular variant of PTC. As opposed if we see a combination of RAS plus TERT. So this is a graph that shows on the blue RAS, isolated RAS mutation. Disease-free survival is really close to 1, right? BRAF, same. Now, if you combine RAS and TERT, or RAS or BRAF plus TERT, the disease-free survival goes down considerably. So the combination is what confers a worse prognosis rather than isolated RAS, isolated BRAF, even isolated TERT. And these are all the studies that were published around this area. So what is the risk? This is a study that was done for the risk assessment of distant metastasis in differentiated thyroid cancer using molecular profiling. And it was a case-controlled study of 62 patients with differentiated thyroid carcinoma plus distant metastatic disease, distant metastasis. So it was thyroid B3 was used for molecular risk stratification. Low risk, this was divided in low risk alterations, RAS and RAS-like, intermediate, BRAF, B600E, BRAF-like and copy number alterations, and high risk, TERT, TP53, AKT1, and PIK3CA. And among patients with DTC plus distant metastasis, 66% had a late hit mutation, were found to have a high molecular risk profile, TERT, TP53, PIK3CA. 32% had intermediate risk molecular profile, and only 1.6% had a low risk profile. So it's very reassuring that when we found this, it's either a benign condition, benign adenoma, or a low risk thyroid cancer. So I'm really close to my time. These studies showed again a combination of TERT and BRAF. BRAF TERT, again, what are the coexistent implications and clinical pathologic features, recurrence and survival. Again, BRAF alone was a poor predictor. TERT had mixed results, but alone also not a very good predictor of prognosis. But if you combine BRAF plus TERT, that was a strong predictor of poor prognosis. So it's a cost-effective strategy. This is one of the studies that was done evaluating cost-effectiveness. So cost of GSC versus cost of lobectomy, and you have 4 countries here: UK, USA, Australia, and Israel. So the cost of GSC, it's almost the same for every country. But if you look at the cost of lobectomy and the USA, it's much higher than any other country. So compare UK, this is the cost below 7,000. Australia, same. Israel, same. But the USA, much higher. So in the USA, the cost effectiveness is better for molecular testing rather than lobectomy as compared to some other countries, at least for now. So what are my key points and conclusions? The negative predictive value of molecular testing is uncertain real-world practice, as only a minority of molecular benign nodules undergo surgery. There's a lack of gold standard histopathology, and we talk about that on the comparison and the gap of the real-world performance versus the validation study. We need studies with long-term clinical follow-up of molecular benign indeterminate thyroid nodules, where benign behavior is a proxy for benign histopathology, are still needed. And genomic profiling of positive nodules may have prognostic or therapeutic implications, and this is an emerging area. Thank you very much for your invitation.